And there are demographic differences here. So for example, the profile of exertional heat stroke would be your young, middle-aged worker, and is typically associated with physical work or exercise under heat stress. So under hot conditions, right? Whether it's the sun or whether it's hot works. On the other hand, classical heat stroke is associated with the elderly with a physiologically diminished thermoregulatory capacity. And that can be due to chronic illness, that can be due to age-related maturity. And that is the group that is the old person sitting at home in a particularly hot summer's day, dehydrating, and with no real exertion gets classical heat stroke. Okay, so in our minds, we need to understand that from an occupational perspective, we're actually talking about exertional heat stroke. The other point to appreciate is that we want to differentiate heat stroke from the rest of the heat-related illnesses. And I'll look at this differentiation from two perspectives. So the first perspective is on the symptoms. If you ask what is the diagnostic criteria for heat stroke, you need temperature more than 40.5 degrees Celsius, so that's body temperature, and central nervous system dysfunction, so CNS dysfunction, confusion, delirium, epileptic fits, loss of consciousness. So a combination of these two, increased temperature together with CNS dysfunction, would lead you to a possible diagnosis of heat stroke. Other symptoms, multi-organ failure, hypotension, you can consider that a very early sign, sweating or lack of sweating, these would be considered secondary symptoms. They are not primarily, they're not in a primary diagnostic list. One thing to note here, why I put anhydrosis or lack of sweating in brackets, is that there are many case studies where, and I would say medical legend, right? You pass down from physician to medical student that, you know, be careful of the heat stroke that comes in and the person is no longer sweating. That is a very dangerous sign. This person has lost the ability to sweat and therefore to thermoregulate. Yes, while that is true, from an occupational exertional heat stroke perspective, do take note that easily 90% of the occupational heat strokes you see will not exhibit anhydrosis. They will exhibit heavy sweating. Anhydrosis, or the loss of sweating, is more associated with classical heat stroke. So your elderly, which have got physiological degradation of their thermoregulatory system. When we look at the other heat injuries, so from heat exhaustion, heat cramps, all the way down to heat rash, temperature tends to stay below 40.5 degrees. It's associated also with sweating, cramps, and then the non-specific symptoms, headache, dizziness, nausea, vomiting. On examination, you may get tachycardia, you may get mild hypotension at that point in time. So that's from a symptom perspective, that there's a clear difference between heat stroke and the rest. From the physiological perspective, so if you look at the chart on the right, if we understand that heat causes increased core body temperature, which leads to sweating, the other physiological response is an increased cardiac output. So fundamentally increased heart rate. And the reason that happens is because the body will begin to decrease the blood flow to the organs. So it's saying, nope, all you kidneys, you know, we are going to give you less blood. We're going to send all this blood to the skin. So you're getting a vasodilatation. And the reason for that is for thermoregulatory purposes, right? We need to get the blood to the surface so that we can cool the body. And as long as the body can keep up, as long as the body's cardiac output can keep up with this demand, of peripheral vasodilatation and the cooling needs, you stay outside heat stroke. That means you're within the compensable range. And that's where heat exhaustion, heat cramps all sits. They all sit within the compensable or physiologically compensable pathway. However, once we begin to lose the ability to maintain our cardiac output, we will see a decrease in central venous pressure, and then you begin to enter the non-compensable pathway. And that is where heat stroke sits. And heat stroke sits in the non-compensable pathway. And here we have come to appreciate that heat stroke is an inflammatory response from heat exhaustion and heat cramps. So once you enter into the non-compensable realm, we are basically at the beginning of a systemic inflammatory response pathway. There are classically described 3 phases of heat stroke, but the main phase that we as primary practitioners tend to be interested in is actually the acute phase. The hematologic, enzymatic, and the renal hepatic phases, these occur 24 to after the heat stroke has commenced, and this is where you begin to get your rhabdomyolysis, your DIC, disseminated intravascular coagulation, and your systemic inflammatory response syndrome. So for us, we are more interested in the acute phase. So at the front line, what are we going to do? So the first thing we need to do is to make sure that we are able to diagnose heat stroke. So your sweaty, confused man in hot weather that comes in, you examine, you've got a tachycardia, person's got a tachycardia, plus minus a mild hypotension. We still need to exclude some of the common causes of this clinical picture. You need to exclude your myocardial infarctions. You need to exclude your strokes. You need to exclude all your diabetes-related conditions, whether it's hypoglycemia, whether it's DKA. Less likely to be HHNS, that's your hyperglycemic hyperosmolar non-ketotic syndrome. Those tend to come in a bit warm, but they tend to be very dry. They're very dehydrated in HHNS. Drug overdose, especially with prescription opioids, those tend to come in sweaty, but tend to be colder. They're not as hot. And then the infections. And this is one of those that tends to cross and becomes a bit confusing, because you are going to get a high temperature, you are going to get the CNS disruption because of the meningitis or encephalitis. So at that point in time, the key differentiation between something like meningitis, encephalitis versus heat stroke is going to be the history of exertion. This guy or girl is going to come in with a story that, I've been doing heavy work under the sun. And so if the temperature is high, above 40.5, and with a history of exertion, you've excluded, at least on history, all the other common things on this list, you are likely to be looking at a heat stroke. When we say take the temperature, the gold standard is the rectal temperature. But to be honest with you, if you have someone coming in confused and you are not a clinic that sees heat injury on a regular basis, it is going to take time to A, find your rectal thermometer, B, actually disrobe the patient to a state where you can take a rectal temperature. For most of us on the ground at that point in time, I think we lose too much time trying to take a rectal temperature. So what I generally do is that we take an initial tympanic temperature from the ear, and if that's high, we roll with it. We run with that first. We can take the rectal temperature much later. We can take the rectal temperature at the hospital. That's perfectly fine. I think if at that point in time you have a high tympanic temperature and you already have signs and symptoms of CNS disruption, we can treat as a heat stroke. So what do we do? Now, while it is tempting that say, oh, heat stroke, quick, let's cool the patient. Let's not forget the ABCs, right? Airway, breathing, circulation. So all your basic CPR, ACLS protocols come in first. Make sure we've secured an airway for the individual if he's unconscious. If he's conscious, then that's fine. He can maintain his own airway, give him oxygen, set an IV line, pump the fluid in because he's likely to be dehydrated, slightly hypotensive, he is tachycardic, give him the fluid support. So do all that first, and then call the ambulance, right? Call the ambulance, then begin body cooling measures. What do we mean by body cooling measures? At the most basic level, it is to take off the clothes and the PPE up to underwear. So we preserve modesty up to underwear and put into a room where there's at least a fan. Now, I say that because not every clinic is configured to go further than that. Ideally, what we will want is ice packs. And we can put ice packs at the neck, the armpits, and the groin. But to have ice packs to put, you must be prepared. You must have had a fridge, and you must have the ice packs in the fridge already. Ideally also, after we put the ice packs on, if the ambulance hasn't arrived yet, we would want to use cold, wet gauze sheets on the body. It can be gauze sheets. It can also be a towel. Essentially, you are wetting these towels in ice cold water and then putting onto the arms, the legs, and the chest. And then every 2-3 minutes, you change. This is what would be reasonable for a clinic to prepare if they are functioning in an area or district where you know there is a risk of heat stroke coming in. If you are really high risk, then actually the gold standard is cold water immersion, which means you want to have a plastic bathtub, okay, which you are prepared to put water and ice packs in to cool the water down, and then ask the patient to sit in that tub. Okay? But again, that is not going to be common for many GP clinics. Then of course, after you've initiated all this body cooling, if the ambulance has arrived or if there's no ambulance but you need to do the primary evacuation, then evacuate to a tertiary.
Recording
if
in
we're
progress.
asking workers to do high physical work in a very hot and humid day, if we are asking them to operate in a hot environment while wearing very thick PPE, so this can happen in hot works when you're dealing with furnaces, molten metal, and so it's a hot environment, and yet they have to wear thick gloves, they have to wear thick overalls for protection purposes. And if for whatever reason the company realizes that there's a lack of provision of sufficient drinking water. So these would be the initial environmental and work factors that would increase the risk of a heat injury occurring in the workforce that day. On top of that, you can layer on the personal factors. So the older worker is at higher risk of heat stroke for the same reason as the elderly at home, right? We have some degradation of our physiological thermoregulatory capacity as we age. If the worker is overweight, if the worker is suffering from an acute illness, so an acute upper respiratory tract infection, or a chronic illness, diabetes being one of the most common ones that interact with heat injury. If the worker is on certain types of medication, diuretics, the anticholinergics, the antihistamines, some of the psychotropics, especially the benzodiazepines, right? These can predispose that worker to heat injury. And lastly, we actually, of the last 10, 15 years, we've begun to see evidence that suggests there is some genetic predisposition. So if a worker has had heat injury before, there is a chance that this worker has got a genetic predisposition to heat injury as well. So these are the factors that the workplace has to take into account as it begins to look at how do I plan work in order to make sure that my workers don't suffer heat injury. From a more practical level, they're going to ask you, okay, doc, you've told me all these risk factors. What can I do? Okay, this is the list. This is what a typical company can do without significant increased costs. The first thing to do is to be able to educate them to execute basic fitness to work, which all it means is that please identify if any worker who is ill, who's got a URTI, who's coughing away, who's still recovering from their URTI, who's not perfectly well. So it's the first thing that a supervisor needs to be trained to be able to recognize. Secondly, is for the provision of appropriate clothing. So if you're going to be working under the sun, loose-fitting, light-colored clothing. Cooling vests. Cooling vests is controversial. We have seen cooling vests deployed in China, in Japan, in Korea, in some of the workers. More commonly, if you watch on TikTok and all that, you actually see police, those traffic police in those countries. Sometimes they're issued with cooling vests. The problem with cooling vests, and what we need to appreciate about cooling vests, is that all cooling vests, no matter what sort of technology, of which the basic technology is chemical ice pack, fan, and water circulation. So these are the common types of technologies that are embedded in cooling vests. No matter which type, they all come with a logistics requirement. You need a freezer for the chemical cooling packs. You need a battery support, some way to recharge the fans. So they all have some logistic overhead that's required, which makes it not practical for every company to deploy. Provision of water. So you must provide water. For some of us in built-up areas and urbanized areas, you may think, well, there's water everywhere. Yes, but do be careful, especially when we talk about new construction sites. So if you have a new condominium that's being built, a new shopping center that's being built, the construction site may be naive at that point in time, meaning water has not been piped in yet. So workers working 500 meters away from the main gate may not have access to running water. So you may actually need to provide water through water bottles. Singapore experimented with ice slurries. That's the picture on the right, the machine right on the wall. An ice slurry is, depending which country you're in, it's like a 7-Eleven Slurpee, it's like a Korean bingsu, it's like a Malaysian or Singapore ice kacang. Okay, basically we ground up ice and we add an isotonic Pocari 100 plus, that kind of drink into it. And so it's a nice ice cold isotonic drink. So we have experimented with that and found that that's pretty good in reducing body temperature. Then, of course, we provide shaded rest areas. Make sure you schedule, if possible, heavy work away from peak heat and schedule appropriate rest breaks. I'll talk a little bit about this in my last slide. And then education. Okay? Educate supervisors, educate managers, educate workers. You have to educate them in order to understand risk factors, educate them in order to be able to schedule, provide the logistics that I've stated above, educate workers in order to recognize basic early symptoms of heat injury. In my last two slides, I just want to share what Singapore has imposed as mandatory. Okay, that's why I separated this, because not every country has this, and you may not want to impose this on every company. But in Singapore, we have. So the first thing is mandatory acclimatization for new workers. So all workers who have never worked in construction or marine before, especially the foreign workers, some of them coming from colder areas of China, for example, have to go through a 2-week acclimatization program. And in brief, what that means is that when they first start work, and we look at the chart here, they are not allowed to work a full day under the sun. So simply in this acclimatization program, the first 2 days, they're only allowed to work for 2 hours under the sun. Then it goes up to 3 hours, 4 hours, 5 hours, and slowly until they're allowed to work the full 8 hours under the sun. That's essentially what an acclimatization program is. It's just a controlled exposure to a hot working environment. And the most recent thing that Singapore imposed is mandatory WBGT monitoring and rest breaks. So all outdoor work sites in Singapore are now required to monitor WBGT hourly. So this is the wet bulb globe temperature. So it measures dry temperature, humidity, and radiant temperature, and puts it all into an index, into a single reading. And they're required to monitor this. Either if you're big enough, you have to buy the monitor. If you're small, you can go to the national website to get the national WBGT reading. And if the WBGT is higher than 32 degrees, then the company is required to impose a 10-minute rest break under shade for every hour that the worker is working under the sun. Right? So if it's higher than 32, if it's not, then carry on as per normal. And for those of you who have heard of this thing called the heat index, WBGT is preferred over the heat index for this type of purposes because it's more accurate in occupational settings. Okay, I've just about reached my time. I won't take questions now. I'll take questions after the second presentation. Thank you so much for your attention.
Thank you, Dr. Ng. Thank you so much for your presentation. It's interesting to see that we have to detect all this heat stroke and heat occupational related heat injury early on in the acute phase so that we can prevent the complications later. And we have to assess the history and risk factors so that we can actually anticipate and prevent it from happening. Thank you very much, Dr. Ng. So the next speaker, we have Dr. Gogilan Sevaratnam, who will speak on heat rash and beyond. Heat rash and beyond, protecting workers from skin disorders caused by heat. So Dr. Gogilan is a very well-known occupational health physician in Malaysia and also, I think, the world now. So Dr. Gogilan, the floor is yours.
Okay. Good evening, Dr. Ilham. Right, good evening. Yeah, thanks, Dr. Ilham, and to everyone. I'm just going to take a bit of what Dr. Ng has mentioned earlier about heat stroke and the other type of heat injuries. I'm going to look into the heat rashes and things which can cause damage to the skin of the workers because exposed to the heat and also to the UV radiation. Right. So my objectives today, the learning objectives today will be, we look into the symptoms, to recognize the symptoms, the risk factors, the causes for skin-related disorders, and also look into the vulnerability to skin disorders due to heat based on the workplaces and the workers. And very important here is to educate the workers. Workers are our patients, so we're going to educate the workers on the importance of protecting themselves from skin disorders. Well, we all know very well, skin being the largest organ in our body, and it's widely exposed, and people who work under the hot sun, under the heat, will be very much exposed to skin-related disorders. Right, I'd like to start off with a case, a real case which has taken place. This is 42 years old, a mid-aged Asian male, right? So about 3 years ago, he noticed a small irregular shaped mole on his right shoulder. It started growing. Initially, it was dark brown in color. Then later on, he started to have something like itchiness, and it was a bit painful. 6 months after that, right? 6 months, in the past 6 months, the mole started to grow in size, and that's why he started having pain. Because of the pain, he went in to see a doctor to seek treatment, because initially he neglected, he continued as usual. And when he started having pain, then he went to seek treatment. While working during these 6 months, in the period of 6 months, he started to feel tired, experience headache and dizziness. And he always complained it's because of stress and working long hours because, they do a lot of overtime and all that. Since he went and saw the doctor, a biopsy was done. Very unfortunate, it was diagnosed as malignant melanoma. Okay, so it was diagnosed malignant melanoma, and it was like very, very shocking, and he did not expect that. So to investigate further, the question which arose was, what could be the contributing factor for malignant melanoma? Is it because of his lifestyle, habits, family history of having a malignant melanoma, or any type of cancer, right? When they were doing the investigation, right, they actually looked into his work history, occupational history. So there was noted that he was a construction worker for past 20 years. That means when he was even a teenager, he was exposed to heat and all that, right? Working as a construction worker. What does a construction worker will do is they operate all these machineries. They do assist with the building foundation, on the roofing, the framing. Generally, any other construction worker does. Here, being in Asia, this part of the world, where he exposed to open environment, a lot of sun, right? Especially in the warmer month and all that. And on further investigation, he revealed that he hardly uses any sunscreen lotion, sunscreen protection, or even fully cover himself using a hat or even long sleeve and all that. Okay, and as we know that the UV radiation is especially high from 11 until 3 to 4, right? So anyway, he continued work and all that. So from here, it was very likely was related to the job he was doing, right? The malignant melanoma, because they have ruled out his past medical history or family history and also habits and all that. So very likely this was due to due to the workplace and because of the exposed to the radiation, solar radiation. Now, let's look into the types of work and the workplace which can cause heat-related skin disorders. Right, so there are few places here, work areas like industrial work where the workers there exposed to heat, firefighters, in military, mining, and outdoor workers. Our main concentration here would be on the outdoor workers, like those in construction workers, agriculture workers, and also those work as road builders, and they are outdoor workers, right? So compared to industrial workers, there are some type of heat there, but since our theme today is more into climate change and occupational health, we will pay attention on the outdoor workers. Right, let's look into the common skin disorders which arise because of the heat exposure in the workplace, right? There are a few types. Let's look into them, each one, right? My presentation is going to be very simple so that anyone can actually understand and practice these at their workplace when it involves occupationally related. The commonest, I would say, would be heat rash. I think majority of us have seen this kind of case, heat rash, right? So here, the heat rash, they will complain of, the patients will come to our practice, they complain of redness, some kind of discomfort, maybe, some blisters and pimples and all that. And most of the time it's due to excessive sweating, working under the hot environment. The most severe condition would be the sunburn, right? Would be the severe condition if you compare to skin rash, would be the sunburn. Here, what happens, they complain of redness, swelling, but here they will have peeling and the blisters on the skin, peeling of the skin and the blisters, right? This peeling of the skin and the blisters, which cause skin damage, that can increase skin cancer, right? Here, again, the cause of this sunburn would be because of the UV radiation or, again, exposed to a lot of heat. The third one would be the contact dermatitis, another common skin disorders. Here, this can be caused by heat, but also heat along with those exposed to chemicals in the workplace and some kind of cleaning agents and all that. So it would be a combination of causes which can cause contact dermatitis. Here, the workers will complain of redness, inflammation, itchiness, some kind of blistering, and even cracking. The fourth one will be the fungal infections, right? Again, because of heat and excessive sweating, the workers will complain of itchiness, redness, scaling, cracking, all that. I'm very sure all these are very common skin-related disorders which we'll see in our clinic setup. What I'm very concerned would be the fifth one would be the skin cancer. As we all know, the main ones would be non-melanoma and melanoma type of skin cancer, which could be the non-melanoma could be the basal cell carcinoma and the squamous cell carcinoma. Again, this is because of the sun exposure, all right, because of the climate change, because of the UV radiation exposed to, and the symptoms here would be they will have some kind of changes in the skin, new growth, changes in the mole, or the wound that doesn't heal. So this is something that we have to pay attention, right? And my next two slides will be talking about the skin cancer, the data on it, right? WHO, right? The WHO has mentioned about this and they have come up with the data here, right? Here, even the WHO Director General, Dr. Tedros, have already said that the unprotected exposure to solar ultraviolet radiation at work is a major concern, right, of skin-related cancer, right? So here, the data here, in the past 10 years, between year 2000 and 2019, in that 10 years, the death from the non-melanoma skin cancers due to occupation has doubled up, right? Almost 88%. And in 2019 alone, almost 19,000 people in many, many countries around the globe, right, have died because of non-melanoma skin cancer due to working outdoors in the sun. And majority of them are male workers. I mean, you can see that in construction worker, agriculture, the road builders, majority of them are male workers. So this actually gives us something to think of, that a number of cases which has been reported. The other data that I could find is data from Australia here. Australia, the skin cancer is very commonly diagnosed. And from that, 22% of the workers had skin cancer due to workplace exposure to the UV radiation. In the European Union, between the year 2013 and 2021, more than 33,000 cases of occupational cancer were reported. But here it's not just the skin, it's generally all the occupational cancer were reported, but mainly because of the exposure to the UV radiation, again, due to the climate change and the workers who were exposed to it. Right, this is something that I like to emphasize is, what will be our role? What will be our role? How are we going to manage occupational skin at the workplace? What can we do, right? So the first and foremost important thing is to take a detailed occupational history, right? As what Dr. Ng, as the previous speaker has mentioned, right? The sign and symptoms will be generally the same, right? Now, we want to tackle these cases of work-related skin disorders. So very important will be a proper occupational history. We're going to ask what they do, a detailed job description. What did they do? And what are they exposed to? Do they expose working under the hot sun or some kind of chemicals and all that? The duration of work, how many years they have worked? Do the other colleagues have similar problems? Do they have their colleagues, do they have the similar problems like having rashes or even having some kind of itchiness, peeling of skin and all that? So to take a proper occupational history, the moment we suspect it is related to work, right? If the doctors will see it's not an occupational health doctor, probably he can refer this case to his in-house occupational health doctor or an external party, where the occupational doctor with his team and occupational practitioners will actually conduct a workplace assessment. This workplace assessment is conducted to confirm what has been taken from the occupational history, right? So at the workplace, being an occupational health doctor, we prefer to see our patient or our workers at the workplace. After seeing them in our clinic, we like to see them in their workplace so that we can really do the assessment to see what are the hazards they're exposed to and what is the risk that they are exposed to. How risky are they, right? So when you are there, you also be looking into what type of protection are they using now. Is the protection is enough, sufficient, and all that? Here, you need the expert and occupational practitioner. That's why this case has to be referred to an occupational health doctor, or even we ourselves, if we are able to go to the workplace and we can actually look into the assessment here, right? Then, the same time, when we see the patients who has some kind of skin changes in the skin, the wound has not recovered, right? Non-healing wound or some new moles, I think we need to refer this to a dermatologist for further treatment, for biopsy and all that, which we can't do it at our level. So we have to refer these cases, right? So when they are in the workplace, right, we have to do this skin screening test. Some of the skin screening tests can be done by the workers themselves. I mean, it's very simple. They can just check whether they have any changes in the skin and all that, which I'll tell you in the next slide. Right. So the management here for the workers is one of the important thing would be the educating the workers in the workplace. Very importantly, we should also mention earlier in the previous presentation is the sun protection using the sunscreen lotion. And here, many journals have mentioned that using broad spectrum sunscreen lotion with the sun protective factors 30, the index of 30 or higher, that it should be applied every 2 hours. Here, the employer has to provide without charging the workers additional costs. That means they have to provide to the workers for them to apply this sunscreen lotion before they start work and every 2 hours. I think this has been done in many places, and it's just that they don't actually continuously use this kind of sunscreen protection. The next would be taking a lot of fluid, drinking a lot of water, right? A simple cold water is good enough. Maybe in some places they have come up with a lot of different type of drinks and all that, right? So they have to stay hydrated because that can prevent a lot of skin issues. The next would be the protective clothing. Very, very important is that we have to ensure that the workers fully cover as much as possible, right? If possible, every part of the skin are covered. Okay, so like wearing a white brim hat, sunglasses, long sleeve shirts, and all that. Right? These are not very expensive because in this part of the world in Asia, we have to go to their down to that level, and we have to advise them this kind of protection, because we're going to advise them expensive management control measures that's going to be very difficult for them to continue, right? So simple things like wearing hat, sunglasses, and long sleeve shirts and all that. In between, they have to take breaks, short breaks and all that. And when they take break, they have to rest under a shelter or under a shade. That is very important. So that will reduce the exposure to sun. If we could manage to speak to the employer when we are at the work, right? When we have a case of heat which caused skin disorders, when we are at the work, we need to talk to the employer, and we can probably advise them whether they can reschedule the work. This comes under the administrative control, where probably they can start early and then and in between they take break and then they continue till late evening, right? They can do this. Right, so that to avoid, as we know, the UV radiation, right, is the highest between 11 a.m. to 3 p.m. So if we can avoid that period of time, right, maybe the workers, they can do something else in a shaded area during that hours, and after that they can go out and they continue their work under the sun and all that. Regular checks, very important. This is something that we have to inform. Very simple, to teach the workers, to teach the our patient that please always check whether they have any changes in the skin. I mean, they would know, right? Because they always check and all this. So when they see any changes, even if they think there's slight change, to seek treatment as soon as possible. Right. So my last slide, in summary, this is what has been practiced in many countries, known as the Sun Smart 5S to workers. Very simple. We can at least give this flyer to them, or we at the workplace to do health promotion or health education for the workers. Those who are outdoor workers, we can give this kind of advice: sleep, slope, slap, sit, and slide. Right? Sleep, what we have done, sleep is to cover your skin, the worker's skin, as much as possible, right? And then apply sunscreen lotion, right? Every 2 hours, make sure it is more than 30, the sun protection factor more than 30, and wear a brim, white brim hat to protect their face, neck, and ears, and also to seek shade. Whenever possible, we have to tell the employer, please allow them to rest in a closed environment, right? Even if it's 10 or 20 minutes in a closed environment.
Recording in
practitioner,
progress.
Respective whether an occupational physician or we are as a general practitioners and all that, the simple thing that we can advise our workers. With that, thank you very much.
Thank you very much, Dr. Gogilan, for your insightful. We can give an applause. Everybody can react with the clap. Yes, thank you very much. Thank you to both of speakers for their insightful presentation. We'll now open the floor for your questions. So please submit them via the Q&A panel, and we'll address as many as we can during this session. Now we open the floor and then we'll discuss. We will also be displaying some polling questions at the start of the discussion. Please do vote so we will know what you think. So let's have all our panelists in, because I'm very happy to welcome our panelists for our discussion who will be joining Dr. Ng, Dr. Gogilan, and myself. Professor Dr. Pham Li An, he is a professor in family medicine and chairman of the Vietnamese Association of Family Physicians. He is from Vietnam. And Dr. Handoyo Kun Hendrawan, he is an occupational medicine specialist doctor and representative from Indonesia Occupational Medicine Association. Dr. Abdul Jabbar D. Esturko, he is a chapter president of Zamboanga Peninsula from Philippines, College of Occupational Medicine, Philippines. Dr. Sunil, he is the director of Association of Healthcare Providers, India. And last, Dr. Monalisha Sahu, she is an associate professor and head department of occupational health of All India Institute of Hygiene and Public Health. Welcome all panelists. So before we start our discussion, let's do some polling. And we have a quick poll on the topics that we have covered. So the first poll is, which of the following is not a contributing factor to heat stroke among workers? This is very easy, 100%. Heavy physical workload, adequate hydration, wearing impermeable clothing, high environmental temperature. So which one is not a contributing factor? I think we can just give you 5 seconds. Too easy. Please do vote. Has everyone voted? Let's see the poll. Okay, now can we have the answers? The answer for the poll is adequate hydration. Okay, so which will the organizers show the results? Because if we can actually go to the next poll. And we can start our discussion earlier. So which of the following is not a common cause of heat-related skin disorders in the workplace? So prolonged exposure to high temperature, excessive sweating and friction, wearing breathable and moisture-wicking clothing, lack of proper hygiene and protective measures. So please key in your answer. Okay, so the answer is wearing breathable and moisture-wicking clothing. So that's not a common cause lah, because that is actually a preventive measure that you can take to prevent you from getting a heat related illnesses. So I've just become a Malaysian just now. I just said lah. All right, so let's go for the questions. Any question from the floor, please? I'll read the Q&A. So we can start a bit on the heat stroke prevention strategies. From your experience, doctors, what are the most effective preventive measures employers can implement to reduce the risk of heat stroke in workers? And how can these strategies be tailored to different industries? I think Dr. Ng and Dr. Gogilan has covered a lot of it, but maybe in India, you can share the most effective that you have seen. Dr. Sunil? Dr. Sunil, we can hear you because you're muted. You can unmute yourself. Yes, Dr. Sunil.
Thank you, Ilham, for asking these questions. See, the most effective preventive strategies for heat wave includes, we need to have early warning systems. There has to be dissemination of timely alerts and heat advisories to the communities and the workplaces. And second one is hydration and, the access to the cooling. You need to have ensure that the access to drinking water, access to the shaded areas, cooling stations, and then also the work schedule adjustments like shift work to cooler parts of the day and reduce the physical exertion during the peak heat hours. So public awareness campaign is equally important. We need to educate the public on the signs of heat illness and self-care during the heat waves. I think the last part I would like to add here is that, building design. So you need to promote ventilation, insulation, and the cooling at homes and in workplaces. So these are the important, strategies which we can with which we can prevent the heat waves effect.
Thank you very much, Dr. Sunil. Dr. AJ Esturko, do you want to add anything from the Philippines side?
Yes, good evening, everyone. Now, I think one of the most important would be like in the systems approach for like in the government here in the Philippines. As early as like 2016, we have a labor advisory on heat stress on our private sector. And I think we have a rehash of that labor advisory in 2023 as well. Well, it outlines basically all of those that mentioned by Dr. Gogilan and Dr. Nang. Especially the acclimatization, the provision of water. It's cost effective actually for employers. One of the on the negative side of it, it's a voluntary implementation of companies. So it's not actually mandatory for all companies to implement it. It really depends on the resources of the different companies. Of course, we have to consider that, the employers, of course. And then the implementation of the risk management. So it's a standing order. If, for example, the state-run weather bureau says that the heat index, Dr. Nang, here in the Philippines, we still use the heat index because the companies here cannot, of course, the austerity measures of the companies. And with that, we will be like asking for waiting for the advisories of the state-run weather bureau based on the heat index, and there we will be deploying the appropriate implementation for that day or for that week.
Thank you very much. It's interesting to see that in Singapore they've made it a law, but in Philippines the rule is there, but it's optional for them to follow according to the place. What about Indonesia, Dr. Handoyo? Have you ever seen a single most effective, or is it a combination of everything?
It's combinations. In Indonesia, our manpower ministry issued a resolution on 2018 that we have to do the monitoring WPGT. But in this situation, I believe that monitoring hourly is like Singapore recommendation is better one, but it's more costly too. I think besides that, monitoring WBGT, training, teaching the workers on the risk and the prevention is also important. For instance, drinking, if you rely on when you feel thirsty, it's not applicable in this situation because you already have acclimatizations. Your thirsty will not accurate anymore. So we recommend the use of urine color.
Urine color. Oh, wow. Okay.
More than the feeling of thirsty. Yeah.
Mm.
And then other thing is teaching them on the risk. Also on the medical practitioner side, because some practitioners believe reducing the temperature too fast is not good. But we know, as Dr. Han presentation, that must be reduced the temperatures to prevent heat stroke. And some practitioners still believe let do it slowly.
Thank you very much, Dr.
We
Handoyo.
cannot do it slowly. We must do rapidly. But we also have to monitor the electrolyte imbalance in heat stroke, especially if we want to do the rapid actions.
All right,
I
thank you
think
very
that's
much. Yes, very insightful from Indonesia. I have a few questions still. Very interesting. I think I will get Dr. Pham Li An to answer this because this is about family physician as well. What are the usual effects of hot temperature in the eyes of the worker? And for office workers, doctors, they want some advice on air conditioning temperature, the recommended water intake, the rest regime. I think that is already covered. It's more of some advice on the air conditioning temperature. I think it's about the best temperature to work in lah. Okay, so Dr. Pham, usual effect of hot temperature in the eyes, as well as advice on air conditioning temperature, rest regimes. Do you have any guidance documents? That was the question. Prof, can you hear me?
Yeah, thank you very much for so interesting questions. For the eye, symptom in heat related to illness, we can see some symptoms. Look at your dry eyes. That's very common in the health worker due to dehydration and high evaporation in hot and dry environment. And this symptom can cause some blurry vision, intermittent redness, irritation, increased blinking or eye fatigue. That can cause the accident if the worker they work in high altitude, for example. The second one symptom is the eye irritation from the heat sweat. And also, they can, if they wear the helmet or Google use, they can cause a burning sensation, tearing, foreign body sensation. It's so dangerous for the worker when they work in high altitude. The third one, they can cause a visual disturbance. And the fourth, photophobia. And also for the family physician, our role, we have to identify the red flag for referral. For example, the symptom the worker they should
Recording in
terminal
progress.
vision. It have to send them or refer them immediately to the hospital. And also, we have to have to go to the health promotion. For example, to encourage workers to wear sweatband, UV protective eyewear, ensure adequate hydration, or rest in the shade. So we have to include all of them in the curriculum for training our students in the general practitioner. It's very important for the future. Thank you.
Thank you very much, Professor Pham Lee An. Dr. Mona Lisa, we actually have a very interesting public health question for you. What can I do at a community level as a public health specialist for agricultural workers working on farm to prevent health issues like skin disease, respiratory illness, and heat stroke? Because as you know that people who work at farm, they would work under the sun. So the question was, what can I do at the community level as a public health specialist or agricultural workers to prevent all these health issues like skin disease, respiratory illness, and heat stroke?
Yes, Dr. Ilham, thank you for this question. So we were recently working on this occupational group where farm workers were involved, and what happens in India, mostly these farm workers and agriculture workers, they come under the unorganized sector. So they have, first of all, they have very less awareness about all these things. And so specifically, it is important to increase their awareness. And you will be very surprised to know that as it is an unorganized and unregulated sector, many a times they are dealing with toxic pesticides, even some agents which are so toxic which may cause instant death without proper PPE. So if we increase their awareness and if PPEs can be available to them, like when they are dealing with those guys, so wearing proper hand gloves, and which are not reacting to the chemicals, and also then proper masks, and they are not, even the general masks are not available many a times to such workers. So even the masks, which are very important, and also they work in the sun for very long stretch. So having breaks when the heat is very high, every 20 to 30 minutes, even when they are not thirsty. So these are very important measures, and at least also not possible for these appropriate PPE, and then taking breaks is very, very important to maintain hydration and protect them for.
Okay, so what public health measures can be taken? Samira maybe can add a bit. Dr. Mona Lisa, we are actually losing you a bit at the end.
Coming.
Is it just happening to me, or is it the whole?
Earlier, am I audible?
We are losing you a bit at the end, but now I can.
Yes, coming to the specific measures. So India is now having a basic occupational health services guidelines. So in which we can, by Ministry of Labor and Ministry of Health, we can act specifically on raising awareness and then we can connect them with the existing healthcare system, and also we can provide them with certain social security, like for specific for unorganized sector, there is this e-Shram portal where they have to put a certain amount of money annually, and then they will be benefited with social security, especially related to their medical expenses. So those things, many people are even not even aware of this policies. So with such kind of policies evolving, I know lot is still there to be done, but we have begun somewhere, and we have to go a long path ahead. But these are the public health policies which are being taken into place, and many workers, they are already coming under the purview of ESIC, employee services. So there also they can receive this medical care. So these are the ways in which the employees can be, the farm workers specifically can be helped.
Thank you very much, Dr. Mona Lisa. Anyone from the panelists can add to that? Maybe Dr. Gogilan from Malaysia point of view?
Sorry, Dr. Ilham. I was busy typing, so I did not pay attention. I was busy answering online.
Oh, thank you. Yeah, because I
So,
can only see the questions that was posted.
What was the question? Because I was busy typing the answers.
The question was actually the public health measures that can be taken for farm workers because they are really exposed to heat.
Oh yeah. I have to make it short because actually there's a very interesting story where there was a group of people. They were exposed to heat. This is in oil palm industry. Plantation, sorry, oil palm in the plantation where they were exposed to heat, and they had to, because of certain, they have to water the plants at certain hours in that day, and actually was noted to have very high UV index. Scientifically proven the pesticide only work during that hours. So that was a bit of difficulty. So the case was discussed and all that. So we tried to do kind of, say, administrative control where we don't allow all the workers to go at one time. So we send them in groups. That means few people will go in, they will water the plants, and they come back, they take rest in the shaded area. Another group will go. We don't allow everybody will go at one point of time. So these are the things that we can do. But then again, there's no one size which fits everything. You have one answer for all. So it's again, you have to go to the workplace and see what are the things that we can do. Thanks, Dr. Hila.
Thank you. Thank you very much, Dr. Gogilan. Dr. AJS Turko is raising his hand.
Yes, ma'am. I would also like to go with Dr. Mona Lisa on the public health approach on the problem of the agriculture. It has been identified that the agriculture sector would be vulnerable actually for the climate change effects of the different countries. We actually have a national adaptation procedures, each of us in the different countries, and it is also identified that in the long term, in the larger picture, we have to adopt a plan specifically on the green jobs plan. So we should not be staying on the status quo that although it would mean problems on food security for our respective countries, but we have to look into different strategies as a country, as a community, as a region, in which we will be able to lessen the risk of these people to be, and we know that the climate change problem, the heat, we already have reached the 1.5 degree as we should have prevented the Paris, the COP, in the Paris Agreement. But it seems that we are already breaching that. But we have to take and enumerate the things that when we talk about green jobs, what are the things that they could shift instead of, or they could take instead of like 4 hours only in the field, and the 4 hours would be on an occupation or a source of living in which they would be less exposed to.
Thank you very much, Doctor. it's interesting to hear that the awareness and the education of the employer as well as the workers are very important as well for them to know about their rights, isn't it? Yeah, so let's go to the next question. Many workers are smokers and have breathing problems, which can alter their breathing and heart rate and more vulnerable for heat change. I give this to Dr. Ng lah. Any recommendations to prevent heat stroke on this population, other than stop smoking, of course?
No, actually, to be fair, I don't think at the moment there's any. I don't think the evidence shows that there is a strong association between smokers and heat stroke. I mean, we don't like smoking, but we try and blame smoking for everything. But I don't think we can blame smoking for increased heat stroke. Yeah. So ultimately, it's still going to be about heat and the work and exertion, and the measures that we mentioned earlier are the common measures that you need to impose, or sorry, not impose, to implement first. Right, everything that's been said so far by Dr. Sunil and Dr. Esterko is exactly that, where you talk about either provision of water, provision of shade, scheduling. These are all the basic cheap measures, right? Measures that any workplace, you can't turn around and say it's expensive to provide water, or it's expensive to provide a shade, because a shade can be as simple as a tarpaulin cloth, pulled over four sticks, right? So these are the kind of things that we would need to put in place first. Thanks.
Thank you very much. There's a question on if a worker has got hypertension, got an acute episode of heat exhaustion, we have to refer them back to the attending physician, right, Dr. Pham Lian, for re-evaluation of the blood pressure.
Sorry, can you repeat that? Yeah.
Because the question is about a worker who previously controlled hypertension, developed an acute episode of heat exhaustion.
Yeah.
Should he be referred back to his attending physician for re-evaluation of his blood pressure?
Yeah, I think it's very important questions because the role of the family physician is the first we care and management the health of individual and their family. What does it mean? We have to identify the risk of the individual or the worker. For example, the risk of emergency care, the first. The second one, the risk of a common disease. The third, the risk of the comorbidity. And the fourth, the risk of the ignorance of the disease. And based on our function, I think we need to take care that patient, that the workers for the full function. Yeah, thank you.
Thank you very much, Dr. Pham. Next question. I think this has already been answered because the question was asking what is there any truly effective, easily accessible solution for the lowest class to know about the harmful effect of climate change. This is about education. Maybe the panelists can actually share with us about how do you educate workers about this climate change? Have you ever had any experience in doing that? Dr. Handoro, is there any, have you ever done it before in Indonesia? Maybe you can share on how to get the workers to understand the risk that they are actually facing.
We can do that in the company, industrial company. We use pre-job safety briefing. So before they start working, our men, industrial hygienists or nurse, give briefing on them. And this can be scheduled in a small group, not in a big group, but small group, but move from one side to the other side. So other thing is using poster and others. But the most important is we must give it the brief training very often, because one time is not enough. They will forget it. So we must do it regularly.
Thank you,
Thank
Dr.
you.
Andrea. Dr. Sunil is raising his hand. Yes. How? I have a question to add to that. How often is often, Dr. Sunil? Oh, you are muted. You are muted, Dr.
Yeah, yes, thank you, Dr. Elam, because this question is very important. How do you educate and train, the workers for the heat illness prevention? I think most importantly, we have to tell them to recognize the early symptoms, the early signs of the heat exhaustion and the heat stroke, which is like, dizziness, fatigue, confusion, nausea, and blah, blah. Then we should also promote something which is called a buddy system. That if a worker next to me, you can identify the symptoms of heat stroke in your colleague or your the co-worker, something, the buddy system to monitor each other for the symptoms. Then the prevention protocols, we need to educate them on the importance of how hydration is important, and the rest breaks are important, and the clothing part, the lightweight clothing. And we also need to educate them on the prevention, like acclimatization, like, they have to gradually expose to heat for the new or the uh, gradually acclimatize to the heat for new or the other or the returning workers. Then we need also to educate them about the emergency response, to do what to do if someone shows the signs of illness, like we have to shift them to the cooler place, apply some cold compressors or water, call for immediate medical help in case of a suspected heat stroke. And most importantly, I think, as somebody was mentioning about the agriculture sector, so we need to customize the content. The training should be customized, the module should be customized for the construction workers, for the agriculture workers, for the manufacturing, logistics. We need to address the unique environment and job specific risks. These are very important. And we can always use various tools and communication like visual aids. We need to have frequent interactive sessions in the local language. Most importantly, at any workplace, we need to encourage a culture of safety, that and they should be reporting without fear, and there should be an open discussion. I think if we use these training. If this is the methodology, if we can follow for the workers, and we can train and educate them on heat illness prevention, then we will be able to save many lives, and save a lot of morbidity and mortality.
Thank you very much, Dr. Sunil. I think we have a last question, but it's a bit controversial, but I don't know which country this question came from, because this question is like, as per my knowledge, there are jobs that require pre-entrance test exposure to extreme heat for a few hours to test their endurance. Every year, there will be heat stroke and heat exhaustion patients as outcome of this test. Is this practice acceptable? Dr. Ng, maybe?
I think it shouldn't be a specific test like this for heat exposure, because there are all kinds of issues that come up from there. Firstly, what are you testing for? Are you testing for acclimatization? Are you testing for genetic susceptibility? And any test that results in a number of heat stroke, for example, it tells you that the test is too severe. So even if you wanted to test for heat susceptibility, you need to find a safer test. So it comes actually back to the basic principle of screening. The tools we use for screening must be safe. So that's the reason we don't do liver biopsy on everyone to test for things, because there is a risk that you can kill someone with a liver biopsy. So the same thing here, we shouldn't test for heat susceptibility using a test that makes people have heat stroke. So if you can find a test that is more gentle, right, some way of indicating potential heat susceptibility without the person actually having a heat injury, then that would be the kind of test that you want to apply for a screen as a screening tool.
Thank you very much, Dr. Ong. Very precise answer. Dr. Mona Lisa, do you want to add anything to it?
Yes, I totally agree to what Dr. Hinton has spoken about that. Yeah, everything we should not assume that it should be tested and it essentially should be tested. Rather, if we act on the preventive part of it, like specifically like Dr. Sunil mentioned about body system, awareness generation, and also very importantly, just this rule of 20, that exposure is to be increased gradually. So rather than employees taking, not following all the recommended standards and pushing their workers to work for longer duration, the adaptation is very much important. So the heat sensitivity will itself reduce if the person is properly following the rule of 20 and is getting the 20% increase in a daytime work in the heat hours, and also taking hydration measures every 20 minutes. So rather than testing everyone and making it like very intensive, it will be more useful if we work on the preventive aspect of it, because hazards will be there. So if we go for hierarchy of control also, here we have to follow the administrative control, rather than if we first can eliminate or we can substitute and reduce, and we can make the environment better with the engineering controls, it will be better rather than just administratively adding on some tests. So yes, so that is my take on it.
Thank you very much, Doctor. At the panelists, I open the floor for any final words to the audience.
Yes, Dr. Ilham, I wanted to answer one more question, which was related to climate change and mental health.
All right.
That was a very interesting perspective, and I got that question, and because right now, whenever we are dealing with climate health, whenever we are talking about climate health, we are mostly talking about heat and physical health. But in my practice and in my research, I have seen very recently, and it was very difficult for me to make it understand to policy makers also, that climate change is impacting mental health severely. So it can be as subtle as nostalgia, leading to like warm and hot weather, leading to anxiety, and then the after effects of it. There can be extreme weather events which may lead to depression and more specifically PTSD. So these changes which are happening, which are affecting mental health of individuals, and in India, like in agricultural farm workers, things are as bad as many farmers are committing suicide. So it is because of how climate is shifting towards a warmer side in our country, and people are not able to cultivate properly. It is impacting them economically. So this whole burden, even this death and morbidities, are because of climate change, which at a larger prospect we are neglecting. So I think it is also a very important aspect which is to be taken care of. And while we are educating them how to like help them physically, we also should take measures of the mental resilience, because it has been seen that if mental resilience is not there, they are not well mentally, then the accident rates and also various morbidities and also the immunity that also declines. So that is also an important aspect of it, and I wanted to speak on it. Thank you.
Thank you very much, Doctor. It's very important. Yes, I agree. Because health is not just physical, it's also on the mental side, isn't it? Dr. Phang, you are raising your hand?
Yes, yeah, thank you, Mom. I agree totally with Dr. Mona Lisa about the heat and related to the mental health issue. We have many evidence, but not strong evidence, because we need a more cohort follow up the research or evidence related to the heat and mental health. And now also I recommend that our knowledge, our today, we have to transfer to our younger generation by integrated to the curriculum for training. Remember when we start to study in medical school, Hitchcock only recommend a few, you see, a few work, a few work, not much like our CMB today, our webinar today. I think it's thank you very much for MIMS and our panelists and our two distinguished speakers today to give our attendees more opportunity to look at the very important issue now. Even though now with the sport, many sport, even marathons, they can get caused some death due to the heat shock. We can prevent them. As we are family physician, we have to recognize the high-risk population, individual and family, and give them the health promotion. Thank you very much. Yeah.
Thank you very much. I think the panelists and the speakers has shared a very insightful talk about heat stroke. The questions on the short-term, long-term health effects and what to do is already been covered by Dr. Ng in his slide, and also Dr. Gogilan during the presentation itself. Thank you very much. And I hope that everyone has takeaway messages that from the panelists for prevention as well as education. The most important is actually to know the risk factors for it so that we can prevent it. If we can prevent it, it's better, as Dr. Mona Lisa said, instead of treating it, we prevent it earlier. All right. Okay. Thank you again for everybody for joining us today. Don't forget to complete the post-webinar quiz for the Philippines participants and claim your CPD points if applicable. And thank you all again for joining us. We appreciate your participation and commitment. See you at the next event. Thank you.
Thank you. Thank you. Thank you.
Thank you,
Thank you,
everyone.
everybody.
Thank
Nice to
you.
meet you.
Thank you all. Yeah.
Thank you, Dr. Ilham, for very
Thank you.
nicely in
Yeah.
the session.
Yeah.
Thank you very much.
Thank you.